Sit to stand activity. It is a regularly performed functional movement wherein center of mass shifts upward as we go from sitting to standing. There is a wide base of support when we sit on a chair, and as we get up into standing, there is less base of support on our feet. Transfer from a more stable to a least stable position. Balance is reduced in this transition. So transfer, which happens within seconds, it's a quick movement, averaging 2.03 seconds and ranging between 1.6 second to 2.5 second depending on individual. Although approximately 4 times per hour a person is performing sit to stand activity. Now transfer is defined as moving center of mass of the body upwards from sitting to standing position without losing the balance, either backward, forward or laterally, in a way without falling. There are phases of sit to stand such as flexion momentum, momentum transfer, extension phase and a stabilizing phase. There is a natural sit to stand strategy and a sit to stand with full trunk flexion, that is before leaving the chair, which is a compensatory mechanism by the patient itself. Why? Because of their gross muscle weakness and usually a combined lower speed of ascent, that is rising. Also it is seen in elderly people. So the seat off is late than the natural sit to stand and efforts of eccentric contraction are increased. Let's look at the determinants of sit to stand activity. So the chair height matters a lot. If the chair height is lower, more will be the sit to stand movement demand. So the lower height increases the angular velocity of hip to stand, increasing the hip and knee flexion. Optimal height is found to be around 80% of our knees height or length. Chair type matters. So our posterior slanting seat negatively influences. How? By tilting the body's center of mass further backward. Using an armrest helps lower moments at the hip and the knee. At the hip, it is seen that a reduction of 50% of extensor moment is found. Speed matters. A faster sit to stand activity gave a shorter flexion phase and momentum transfer phase. Trunk positioning. So in case of more trunk flexion in the initial position, there is a longer sit to stand. There is delayed lift off, found usually in gross muscle weakness and elderly people. The knee positioning. So more the knee is extended, more is the hip moment, about 77% seen. Foot positioning. If the foot is placed posteriorly, there is a decrease in the speed of hip and knee extension. And if the foot is placed anteriorly, there is an increase in momentum transfer. Now coming to the kinematics, we have divided it into phase 1, phase 2 and phase 3. Phase 1 is also known as weight shifting phase or acceleration phase. Phase 2 is known as transition phase. Phase 3 is known as full extension or deceleration phase. Now here, phase 1, it begins with flexed trunk. That is the position in the phase 1. Okay. Now 27% of total movement is our phase 1. The center of mass is displaced forward in the horizontal direction. This phase starts from beginning of the movement until the maximal horizontal velocity is reached. So here upper body contributes to the horizontal displacement of the center of mass. In the phase 2, we have 35% acquiring the phase 2 from weight shifting forward to lifting upward. It involves our phase 2. And the center of mass displaced is both horizontally and vertically. Acceleration is vertical and deceleration is horizontal here. So during horizontal displacement, there is eccentric control from the upper body and the lower limb muscles. During vertical displacement, there is leg extensors that contributes by bringing the hip joint backward upwards. Phase 3 starts from full extension to standing. That involves our third and fourth phase. Now 36 to 100% of the movement is acquired by phase 3. Center of mass displacement is up and in the vertical direction. Deceleration from the maximal vertical velocity of center of mass until end of the movement is there. During vertical displacement of center of mass, again leg extensors helps. Let's understand each phase. First is our flexion momentum phase. Starts with initiation of the movement until just before the buttocks lift off. Here, feet moves posteriorly or backward approx 10 cm. Why? For proper leverage and to minimize work on our quadriceps. Thereby tibia rotates forward, causing dorsiflexion. And as dorsiflexion is happening, there is tibialis anterior activity also seen. Thereby pelvis and the trunk flexes anteriorly to generate upper body momentum. Hence upper body strength are obviously required to create momentum. And if the feet are particularly too far forward, quadriceps will be strained. So this is why feet moves posteriorly or backwards. Next, second is momentum transfer. It is the dynamic stability phase, seen from just before lifting off till maximum of dorsiflexion of ankle achieved. It's the largest ground reaction force seen in this phase. This contributes to transfer from upper body to total body center of mass, upward and anteriorly. In this phase, we have quadriceps, especially vastus lateralis, working negatively to prevent excessive knee flexion or knee buckling. Otherwise, what happens is as the body shifts, the center of gravity pulls it backward into flexion and person can fall off. Tibia is rotated even further forward and increase in dorsiflexion seen. So, tibialis anterior performs positively and soleus controls works negatively to prevent the excessive tibial movement and control excessive dorsiflexion. So most of the force is on the feet here in this phase. Now hip and trunk flexion also continues and head extension is happening. Here eccentric control of from the trunk and the hip is seen post lift off. That helps slow down our forward progression of the body, preventing fall. Next, third one is extension phase. That starts from maximum dorsiflexion until maximum hip extension first ceases. So this requires adequate lower limb strength and joint integrity for extension and or rising. Basically, this is an upward phase of a squat, that is like a squat to stand. So here what happens is plantar flexion is seen. Now you wonder how. So foot doesn't change its position, but the tibia moves backward and creates a relative ankle plantar flexion. There is gastrocnemius and soleus positively working. Quadriceps, especially the vastus lateralis, promotes knee extension. This work here is done by less force than it was done in the phase 2. Next, hip extension is seen via our gluteus maximus work. Tibialis anterior works negatively to prevent excessive tibia backward motion and plantar flexion, thereby maintaining the stability. It is seen that knee extension and head flexion motion are also coming to an end in this phase. This phase has major or maximum hip, knee, trunk extensor velocities and head's flexion velocity reached. Main task of this phase is to translate the body vertically while in a stable position. Lastly, phase 4, that is stabilization phase. This is from maximum hip extension to stabilization achieved. So once we stand up, we might fall off if we are not stable. And in the first, second, third phase of rising, task was to translate the body's segments through space. But in this phase, it is to terminate the translation of the body through space to achieve that stability. So here ankle strategy works, distal to proximal muscle activation. So as the body's center of gravity shifts forward from second to third phase, an anterior or forward sway was seen, also known as forward perturbation. Gastrocnemius and soleus here acts as stabilizers to prevent the tibia moving too forward. Conversely, for some people, center of gravity shifts backward and posterior sway is seen. So here again tibialis anterior acts as a stabilizer, causing an anterior muscle ankle strategy achieved.